much, Ashrani, Robert, Dr. Leonardo, and the editorial board of MetALD for inviting me. Today, I'll speak about liver transplantation in MetALD. I don't have any disclosure, and basically, for this talk, I will speak about the clinical implications of advanced MetALD-related liver disease, especially in terms of prognosis. And I would like to discuss about the trends in waitlisting and post-liver transplantation survival among patients with MetALD, at least in the United States, because data it's not so granular, but at least we have some publications that have been published recently in this topic. And finally, I will briefly discuss about the most relevant plus liver transplantation clinical aspects in MetALD. And in this webinar, we have discussed in depth about the natural history of steatotic liver disease, and we know that patients will progress to cirrhosis, and some of them will present an hepatocellular carcinoma, others will have decompensations, and surely a significant fraction, probably around 5% of the entire population, will require an advanced management, including liver transplantation. And we also discussed about which are the leading drivers of the compensation and progression in these populations. And we know that the metabolic control plays a major role in terms of stability, but also the alcohol consumption, even in those with an advanced stages of MetALD. We also discuss about the prognosis of patients with steatotic liver disease, and we know that individuals with steatotic liver disease are at a higher risk of cardiovascular events. And this is basically because the cardiometabolic risk factors are the drivers of the liver disease. So they are not only at risk of liver-related events, also cardiovascular and neoplasms. And when compare those with muscle D against those without muscle D, we can see that individuals with muscle D are at higher risk of cardiovascular events, but individuals with MetALD are also at risk, even in a lower scale, according to this Asian study. And if we explore the data that was present before in terms of liver-related events, in this large Japanese cohort, we can identify that those who are driven by alcohol are at higher risk of liver-related events. Well, we can see a distribution of major adverse cardiovascular events being higher in MASLD and intermediate stage for MetALD. And MATS also present this recent project on the VA's cohort in the US, showing that individuals with MetALD are a higher risk of liver-related events compared to the MASLD population. So we are talking about a population with a significant cardiovascular risk, but also with a potential ongoing alcohol use and alcohol use disorder in at least 42% of them. So it's important in those with advanced liver disease, especially those who are candidate for liver transplantation, to assess the dimensions of alcohol consumption. And that includes the recent alcohol intake using validated questionnaires, explore the drinking patterns and also the exposure over time to alcohol, even if they are being assess it for liver transplantation, or even if the liver transplantation is contraindicated in this population, because fibrosis and ongoing alcohol use are the leading risk factors for mortality in this population. But also, as I show in the slides before, individuals with MetALD will require probably a relevant cardiovascular assessment, not only for the increased risk of cardiovascular death compared to other populations, because um, this is a significant cause of death in MetALD, but also because if someone is candidate to liver transplantation, we need that he or she arrives in a perfect condition for the surgery. We also discussed about this study. Winston spoke in depth about the role of cardiometabolic risk factors together with alcohol use. So it's relevant to handle both leading risk factors, not only the glycemic control, not only weight, also the alcohol intake. And we are also facing patients who have a hazardous alcohol intake, and around 42% of them will have an alcohol use disorder, or at least 42%. So it's important to also uh, conduct an adequate assessment of them in terms of alcohol consumption recurrence after liver transplantation. This it's just a guide. This is not a very binary decision, but can guide clinicians to better know which is the risk of alcohol recurrence. And in my perspective, I think uh, this is not to strictly say no, this is not a good or a bad candidate, but it makes you better understand which is the prognosis of a patient, and also to plan an adequate strategy for the management of the alcohol use disorder before and after liver transplantation. And what happened with MetALD? Well, this is a recently published study showing what happened in the UNOS cohort. And in the last 2 decades in the United States, we can observe an increase in the waiting list registrations for MetALD. And also in the same year, in 2013, we identify an increase in the liver transplant recipients due to MetALD. I need to acknowledge that this is a study that was made with some codes, so we can identify potential diagnostic differences, but this it's the more granular that we have at this time published. And it's important to also recognize that individuals who had a MetLD, they have a higher risk of weightless removal, all-cause mortality, and graft failure after liver transplantation than those with ALD. So it's not free of consequences to have also a high burden of cardiometabolic risk factors when you're going to liver transplantation. Probably that can have an impact in the overall survival of this population. So when we're talking about the management before and after liver transplantation, it's important to focus on, as I mentioned before, the leading risk factors for cardiovascular disease and alcohol consumption. And we need to take care about the weight changes after liver transplantation, especially the first 6 months after liver transplantation. And also the glycemic control. We know that medications that we commonly use for liver transplantation, including corticosteroids, tacrolimus, and other medications, have a higher risk of metabolic decompensation. Same for hypertension and hyperlipidemia. And we should recommend lifestyle changes to all our patients, regardless the underlying etiology, not only for MetALD, also for MASLD and ALD. And we need to tailor our immunosuppressants according to the cardiovascular risk profile. Probably for those with decompensated diabetes, we'll try to shorten the exposure to corticosteroids. And some medications could have a role, like FGF21 analogs or incretin-based therapies, but we need more information to strongly recommend the use of those medications after liver transplantations. And for sure, alcohol use need to be handled. And it's important to monitor and identify the alcohol consumption over time. And we have the structured interviews, but also we recently have more validated biomarkers for alcohol exposure. And I would like to emphasize what happens in those who have an alcohol recurrence after liver transplantation. This is a study that was published 3 years ago by Ryan Lee, and they identify a significant proportion of patients after liver transplantation that individuals who have a heavy drinking after liver transplantation have worse outcomes, especially in terms of survival. But those effects are not seen in those with non-frequent and non-binge and non-hazardous drinking. So the quantity itself, it's extremely important, not only the recurrence of the alcohol intake. So some biomarkers can have a role in this scenario, like phosphatidylethanol, that it's a very, very stable biomarkers that can capture up to 4 weeks of alcohol intake. It's relatively stable according BMI, according sex, and can even detect individuals who have one single binge drinking up to 12 days. And this biomarker in individuals with MetALD and ALD before liver transplantation has demonstrated a better performance in predicting the survival over time, even better than the self-report alcohol intake and CDT, a suggestion that it's better capturing the alcohol intake in this population. We also published with Federica Tabaglioni from UC San Diego this project showing that this biomarker can uh, increase significantly the identification of the MetALD diagnosis like 4 times and the ALD diagnosis for 3 times. So I think there's a role of the use of alcohol biomarkers before and after liver transplantation, and especially regarding PEth. And if we use the threshold that have been validated for those before liver transplantation and in the overall population, we could identify that those who as phosphatidylethanol over 35 nanograms per milliliter potentially have an actively increased alcohol intake. It's important to mention that phosphatidylethanol can be affected by blood transfusions. So this needs to be integrated in all the clinical settings. And we know also that phosphatidyl ethanol can easily rise after a binge drinking, even if this was just one single alcohol intake. But I think positive PEF, especially over 35, can be a good criteria to establish a more stricter management. And those who have a positive PEF for sure need a proper assessment, counseling, and probably determine the best strategy to avoid ethanol exposure. This is just a suggestion, but requires validation in the further years. And other colleagues recently have published these recommendations before and after liver transplantation for the MetALD population. And it's important to involve individuals with MetALD in teams that have substance abuse counseling. Maybe not for all the patients with MetALD, but as I stated before, a significant fraction of the patients will have an alcohol use disorder. And the use of biomarkers of alcohol use is also recognized by these authors as a potential strategy to monitor the alcohol intake in this population. So I would like to summarize some aspects about the MetALD in the liver transplantation setting. First, individuals with MetALD are higher risk of liver-related events over time, so they will require a liver transplantation in multiple cases. And there has been a substantial rise in the indications for liver transplantation since 2013 in the United States. So when we see a candidate for liver transplantation with MetALD or after liver transplantation, it's important to recommend a lifestyle modification. We need to prioritize the cessation of alcohol exposure, the weight loss in those with overweight, and regular exercise to favor a proper management over time. And we need more data about incretin-based therapies and other potential therapies after liver transplantation. And an alcohol intake evaluation, it's essential before and after liver transplantation. And biomarkers like phosphatidylethanol may be very helpful to identify individuals at higher risk, but this for sure requires more data to provide a strong recommendation. And that's what I want to show you. And thanks again, Ashrani, Robert, and all of the Giraffe board for the invitation. Thank you.